Yes, I can hear you.
Wonderful.
How are you doing, Doc?
I'm doing okay. How's everybody on your end?
We're all right. We have no AC, so it's pretty
Oh no.
toasty. Yeah.
Hey Charles, how's it going, man?
Hey, I'm doing great. How are y'all?
Good, good. We started recording, but we can edit anything out.
Yeah.
Just a pain in the butt to get up and hit record after I sit down. It's being lazy.
I totally understand. I've done a couple of these. Yeah, it's always nice to be able to edit.
Yes, yes. So you looked at the questions I want to ask you, right?
I went over a couple of them. If you know what, I do a lot of interviews and I forget which which ones were yours, but
I got you. I can go over it with you real quick though. It's not too much. So first of all, we just want you to discuss your education and your medical background.
Okay.
And then what led you to develop a passion for treating this mental illness, and describe your methods of treating. I know you use ketamine. So we'll kind of get into the process of that, maybe a history of ketamine. I know it wasn't always used for mental illness. It would start out as like anesthesia back in the 70s, right?
Right. It was, it was initially on the first large scale use was during war. It was called the buddy. It was, the purpose was to have an anesthetic that could help soldiers in the battlefield who were injured. Yeah.
So that's what I read up on it. I looked at your website and I kind of got into ketamine a little bit, just kind of get a background. And then talk about your treatment success rate. And then any negative side effects you've seen with it. And I might hit up what insurance accept this. I don't know, does TRICARE accept this? I'll probably hit that up because we're military.
TRICARE can. That's one of the things we're working on locally here in Chattanooga. I know that up in Murfreesboro, they offer this as a treatment available to veterans. Here in Chattanooga, they don't have a facility that can administer ketamine infusion therapy. Okay. And so we have tried to make ourselves available to them, but with the VA, it's a slow moving process. There's a lot of cogs along the way. We're just trying to maneuver that as easily and painlessly as possible.
Right. And also, I might hit up on the benefits of ketamine or ketamine vices, like being on Prozac or Zoloft or whatever for the rest of your life, or sometimes even more than that. So I know some people are a lot stronger stuff than Prozac.
That's true. Yeah.
Some guys have seen a lot of crap, so they have to really take a lot of stuff.
Yeah.
So, hey, 1 second, Jenny, can you shut that fridge door? I think it's cracked open.
Oh yeah.
1 second, Charles. We'll get started.
Yeah.
And then we'll go. I appreciate it, man. Thanks for coming on with us. Your uncle Mark hit me up about you. I was sitting in his office, and he goes, "I got a guy. I know a guy, my nephew." I was like, "Shoot, that'd be awesome."
Yeah, we've been really excited to have you on, and been looking forward to it ever since we heard about it.
And real quick before we start, so you're a CNRA, right?
CRNA, yeah.
Yeah, I might get you to get into that. I know it's like a amped up version of a RN. It's like a specialty. I know it carries a lot of respect with that title. Just some people might not know what that is, so I might have you explain.
Oh yeah, definitely. We're always eager to explain who we are and what we do.
Awesome, man. So you ready, Charles?
Ready when you are.
You ready, Jamie? All right.
Hey everybody, welcome back to E14 podcast. I'm Jamie Britt.
And I'm Heath Britt.
And together we are E14. And today with us we have
Charles Miller out of Chattanooga, Tennessee. How you doing, Charles?
Real good, guys. Thanks for having me.
Good. Thanks so much for coming on, man. And you're a medical guy. You're in the medical field. Could you tell us a little bit about what you do, a little bit of your background?
Yeah, absolutely. I'm a certified registered nurse anesthetist, which means that we are primary anesthesia providers in the United States who administer anesthesia, specifically in the military. If someone's putting you out and keeping you safe during surgery, that's a CRNA. What we do is we do an undergraduate bachelor's degree in nursing, and then we do either a master's or doctorate in anesthesia. And
Oh,
it's
wow.
just, so we go through, like at my facility, when we train, I went to Middle Tennessee School of Anesthesia, and we train alongside, alongside the physicians in anesthesia. And so it doesn't matter whether you get a nurse anesthesiologist or physician anesthesiologist or dental anesthesiologist, we all train together in the same way.
Okay, what do you specialize in these days, Charles?
Well, since 2019, I have been working here in Chattanooga to educate the community and then provide a service known as Ketamine Infusion therapy. It is a neuroregenerative therapy that stimulates the regrowth of neuronal connections and the reawakening of neuronal lesions. And we'll get a little farther into that, with the conversation, but it's been kind of a game changer in the mental health community. It's a very safe and effective means of achieving what we call neurooptimization. So it's from a mental health standpoint, with depression, anxiety, PTSD in particular, OCD, bipolar 1 and 2, all of these disorders have a physiologic component, and that's what we address.
Wow, we're definitely looking forward to getting more in depth in this after a word from our sponsors.
Welcome back, everybody, to E14 Podcast. With us is Charles Miller, CNRA.
No, CRA.
Oh.
CRNA. It's way easier than saying that.
Oh, you did say it right. CRNA. I thought you said CRA.
Hey.
I was correcting
You know
you.
what I'm talking about.
Wrong.
CRNA, all the way from Chattanooga, Tennessee. So you were talking before the break how you address the mental condition in a physiological way, right? Ketamine. What do you call it? Ketamine what again? I'm sorry, Charles.
Ketamine infusion therapy or ketamine. It depends, it's potato, depending on, the individual. There's no wrong way to say it.
Okay.
But what we do is we stimulate the brain's natural process to self-optimize. We do that by administering a low-dose children's anesthetic known as ketamine. We use ketamine currently in the operating theater still with vast majority of our surgeries. It's a fantastic adjunct. It's very safe. It's good. It's the only anesthetic that preserves the vital functions like respiratory rate, heart rate, blood pressure, whereas all the others will depress those. And so if we have a patient that, say, needs some sedation but can't tolerate your typical anesthetic, ketamine would be the go-to option. It's for small children 6 months and older is one of our go-to anesthetics. It's the preservation of the vital functions is what makes this medication so safe. It's a non-opioid, non-narcotic anesthetic, which is another perk, just not another narcotic is, in the anesthetic cocktail.
So I'm having trouble connecting the dots from mental health and dealing and helping people recover and get better from mental health, like you said, PTSD, anxiety, depression. How does this equate, or how did you come about this ketamine infusion method to treat your patients?
Well, it's I would love to take credit for it. I wish it were my idea. Yale's Department of Psychiatry back in the late 90s, early 2000s, began a 10-year study studying certain types of what's known as NMDA receptor antagonists, which ketamine is one of. There's multiple drugs out there that fall into this category, but and they were all studied to see about stimulating your brain's natural process of neuroregeneration, which is the regrowth of brain cells, essentially. So what they found over a 10-year period when they were doing this study was that we had the ability to stimulate your brain to self-optimize, to self-correct with, I think I mentioned earlier, neuronal lesions in particular. So from a PTSD standpoint, now, and I'm going to try to keep the neuroscience to a minimum. But imagine that your antidepressants that people normally take, say, like Prozac or the SSRIs, SNRIs, that so many of our soldiers are on, they work by manipulating certain neurotransmitters in the brain. And neurotransmitters are the communicators. So think of them like if they were the cars, the neurotransmitters are the cars, the neurons are the roads that the cars drive on.
Okay.
And so what we do is we stimulate a secondary process in the brain to reconnect the neurons, to open up the roads. So it's, I guess, from a mood standpoint, you know, we talked about I mentioned the physiology of mood disorders. So like, if you looked with a functional MRI at a brain that suffers from PTSD, depression, anxiety, you'll see these areas that don't communicate. You'll see, you know, in comparison to, say, someone who doesn't suffer from these things, you'll see these little dark spots that aren't, you know, there's no electrical activity or blood flow.
So the road closed up between those two.
You quite simply, yeah. And it's, you know, for multiple reasons, but it mirrors, say, a traumatic brain injury. You know, it looks like, I mean, if you look at it, it's an area that just isn't working. And so, and specifically in the prefrontal cortex, that's where we're processing everything. That's where, you know, we're able to deal with the present. And as information's coming in, we're disseminating it and putting it away and figuring out, you know, how to keep going from a day-to-day basis. And that's what we're losing. We're losing our processing power with these mood disorders. And so what we do is we stimulate the brain to reopen these lesions, these areas that are turned off. We do that by administering a low-dose anesthetic, a very safe, passive anesthetic, and specifically one like ketamine that's not sedating. So ketamine's not the type of drug that puts you to sleep. It's the type of drug that causes a dissociative state, meaning that it's like a disconnected feeling. And so it means that the brain is still very active. And so when we change the brain's baseline, the brain responds by releasing a protein called brain-derived neurotrophic factor, or BDNF. It's not something, you know, I expect people to remember, but understand, I guess, the part to hold on to is that it's not the ketamine eliciting the change. The ketamine is a catalyst. It triggers your brain's natural process to flood itself with this neuroregenerative protein that each of us create. And that protein helps the brain to wake up these neuronal lesions and over a period of time start to regrow new neuronal connections.
So would you say that by using the ketamine that it's because I think a lot of times when we think about PTSD, we think about being tense all of the time. So maybe our brains are very tense as well. But it would that, when you say like it just kind of relaxes it or so it allows our brains to work properly. Is that kind of what you're saying?
Quite simply, I use a computer oftentimes, and I tell people, like, this is, you know, if you think of your brain as a computer, it has the ability to process so much information at any given time. And so imagine you're running all of these programs and they keep getting bogged down because you're only able to process so much at a time. And so when the brain is not able to keep up with things, it becomes to be overwhelmed. And that feels just like it sounds. You feel overwhelmed with things. You feel like things are coming at you faster than you can handle them. What we do is, by opening up these neuronal lesions, we increase the brain's ability to process. And when the brain is able to process better, the same amount of programs are running as they were the day before. We don't change your life from that side of things. We don't change even who you are consciously. It's a very subconscious process, but what it does, it just makes you better at processing, keeping you, you know, ahead to where you don't get bogged down, making things not feel as overwhelming. So that tension you said that, you know, that naturally relieves because there's just no pressure on you because you're ahead of the curve instead of behind.
Wow.
Man, that's awesome. And I tell you what, thank you for putting that in such layman terms for us, because this sounds like a complicated process overall.
There is a lot to it. Yeah.
Now, what led you this passion to get into this? Because, man, you had to really buckle down in school to get this education, I'm sure, to learn all this.
Anesthesia has always been appealing to me. You know, I did that thing that everybody else did. You know, I thought when I graduated high school that college was not going to be for me, and that I was going to, you know, make it by the sweat of my brow. And you know, a few years after that, I realized that maybe I should rethink that. I got into the housing market and began, you know, my own little construction firm, and that was around 2006. And I'll leave it to you to figure out 2008 was right around the corner, and then the housing market collapsed, and so I had a new direction to go. So I looked for something that was kind of recession proof, and medicine was always on the table. So my wife and I, we refocused, redirected, and I went through, and it took us about 8.5 years to get from start to finish through the educational process. And that was without taking any breaks. That's just how long it takes, at least, and that depends on, it depends on which direction you go, how long it takes. But that was the shortest route for me, and it was eye-opening. And along the way, you start to learn things about pain, about depression, about cognitive function. That's because something I didn't realize before I got into anesthesia, but it's neurology. It's specifically working in the way the brain perceives, neuronal and nerves, signaling. So that's what we do. While I was in it, I was actually more intrigued from the pain side of things. So we treat certain neuropathic or chronic pain disorders. Patients who have, we treat a lot of our vets here locally. They pay out of pocket, but we have special pricing for them. But they've, a lot of them have been through some. I've got a surprising few that have been blown up on more than one instance. Right. Which kind of blew my mind. I would think that once you were blown up once, they would, you wouldn't end up in a position to be blown up again.
And
but
you put a Band-Aid on it and go back to it.
Yeah, here's some motion.
And you should hear them talk about it like it was just no big deal. And I'm just like, you don't seem to understand. You don't understand. No, that doesn't happen.
Right.
In the regular world.
No, that's a big deal.
It's kind of a big deal. Man, these guys are awesome. But almost all struggle with, there's a PTSD that they experience. A lot of them have been, have significant traumas, physical and emotional. Even someone with significant traumatic brain injuries. This stimulation of neuronal regrowth, the regrowing and reopening of these neuronal lesions. It's not just, we don't just treat mood disorders like depression and anxiety. It's been utilized to treat idiopathic dementia, Alzheimer's. It's been used to treat like stroke recovery, specifically help preserve and regain neuronal function. It's a large scale neuronal communication change. It's like upgrading your processor overall. And helps the brain heal faster and heal better.
Holy cow, man! So you were talking about some vets you have a special price for them. So not all insurance will pay for your process.
It's the thing about ketamine is that it's been generic for decades, and so the thing with insurance is that insurance is not obligated to pay for a service that is what we consider off-label use. And since this is the off-label use of an anesthetic, and to get it a label use, we'd have to send it back through the FDA, which they'd have to duplicate all the studies that Yale and Stanford and Johns Hopkins and Oxford did. And that would cost about $16 million. That's the last number I heard put on it. And nobody has that, or those that do have it don't want to pay for it to go through, so all their competition can now accept insurance. It would have to be a very magnanimous push, I guess, to get this repurposed.
Before we asked you to come on our show, this was the first that we've ever heard of this. It's not something that behavioral health doctors are offering to our veterans, or it's just not well publicized. Why do you think that is?
Oddly enough, it's just where we are in the world. So if you go, west of the Rockies or north of the Mason-Dixon line, you'll see this a lot more and used in a much more commonplace. But down here in the South where we live, we're a little slower to catch on, and that's it's one of the things we like about the South. We move a little slower, but where medicine's concerned, it's become a stumbling block. This is the most, because it's not something that is even, I guess, fringe medicine anymore. It's with a few years back, National Institute of Mental Health, former director Tom Sinsel, he was quoted as saying that ketamine given intravenously is the biggest breakthrough we've had in decades. And the reason being is because we've always viewed mood disorders as being either a thinking problem or as I guess a chemical imbalance, like something's wrong. But here's the thing: it's like, how does a chemical imbalance develop? when, like with PTSD. PTSD is a fantastic example. It's, you know, with chronic depression that progresses over decades, we can kind of say that, well, there was always a deficit or something not working right that has slowly led to this. But with PTSD, it's so sudden. And these guys were so functional before
Yes.
the initial trauma, and then they are so crippled by it so shortly after. And so in that case, did their neurochemistry change? And it did, but not because, you know, their body's not producing the right chemicals. It's that the ability to use those chemicals has been inhibited. So how the brain copes with the trauma is it isolates it. And so when something traumatic happens, the brain can't wrap itself around what just happened.
Mhm.
But the body has to go on living. The person has to, you know, tomorrow comes nevertheless, and you have to keep moving forward. The brain will just turn off that section because it can't continually be tormented by this. And we call it's a neuronal lesion. This was, I want to say it was a 2018 study that really looked into PTSD with neuronal lesions. And this is one of the things they found, is that these neuronal lesions are a coping mechanism. It's the way the brain deals with things it can't address right now. It creates
And
a little lesion.
most of your service members will say, they use, I compartmentalize it and carry on, or I put it in a box and carry on. And it's just common language in the service.
Yeah. Mhm.
And, you know, it's something that we do because obviously the mission never stops. So everybody puts it in a box. I'll deal with it later and carry on.
Do we deal with it? That's the thing. Is, you know, the thing is, it never actually gets addressed. And if you think of your brain as a very functional unit, we take in sensory input through multiple ways. You know, we take in things we see, we hear, experiences, and they all end up in the prefrontal cortex to be processed, and then they're stored away after that. But if we can't process it, it stays in that prefrontal cortex, and a lesion develops because it's like the brain reroutes around this area, and that little section is now turned off. And until we turn that back on again, first of all, they never actually process the trauma. And secondly, their ability to process future traumas or future, I guess, stressors of any kind,
Right.
is inhibited. And so what we found is that these guys, they're not just doing, we're not just helping them survive with PTSD, we're helping them resolve their PTSD. I cannot stress enough the difference in these guys after going through this process.
My gosh.
This is absolutely a game changer where PTSD is concerned.
So to put it in super layman terms, Charles, so if I cut my arm, a week later it heals, I'm not dealing with that cut. Is that kind of how you're saying with the PTSD or whatever mental illness somebody might have? Is that how they get healed to that extreme?
I think it is to that extreme. There's still the
Wow.
scar there. We can't take the experience away,
Right.
but we're able to put it away. Whereas before it was just kind of sitting in the front of their brain, kind of always something that was torturing them over a period of time. It's not sitting there anymore. It's put away. And if they want to delve into it, they have every option to go back to that drawer, pull it open, and check it all out again and go through it again with their counselor or with their mental health provider. But it's not something that bleeds into the moment, because that's what these guys are losing. They're losing the ability to be present.
Yes.
Without these invasive thoughts and traumatic memories bleeding into the moment. And if you think about it, the moments when happiness happens, the moments when contentment happens, It doesn't happen in the past, it doesn't happen in the future. And so the inability to be happy or be present, that's what they're losing is contentment in just being. And when you don't have that, it makes living day to day very difficult.
That's true. Oh my God, that's awesome. So let's talk about the process of the ketamine infusion. Like when they go to your office, what can they expect?
Okay. What it looks like from our side of things is you come in, every single patient that comes through our door, before we consider treating them, we do a consultation. A consultation we never charge money for. Each consultation, you get one-on-one with one of our providers, whether it's me or one of my colleagues. And we sit there, and it takes about an hour to hour and a half, depending on the individual. And it's a time for us to get to know you better, because the 15-minute consultation isn't going to cut it. We have to be able to kind of peel back the layers and talk about what went through and make sure that the patient has a good understanding about what we're doing here. There's a lot of stigma out there. There's a big push right now. Everybody loves the concept of what we call psychedelic therapies. unfortunately, psychedelic therapies are not really psychedelic therapies. There's, people out there using, ayahuasca or MDMA or LSD or even psilocybin. And all of them actually do something very similar to what our anesthetic ketamine does. Is it changes the brain's baseline. When you change the brain's baseline, your brain has this wonderful backup protective mechanism that floods itself with this protein to preserve communication and to minimize any potential damage from whatever's changing its baseline. It's a safety mechanism built into all of us. If somebody hits you in the head with a hammer, that same protein would release. It's a way of our body protects itself. We just trick that process with a very safe and very passive anesthetic. The other methods, they all work to an extent, and I've talked to many people, servicemen and just, civilians alike, that have experimented with psilocybin and seen some improvement in their struggle, but it's limited. Right. It's because it's not controlled, it's not measured, it's not as perfect as an administration as what we can do with a time-tested and daily utilized anesthetic.
And changing that baseline on your brain could be kind of dangerous, right? I mean, you're changing your natural.
What it's doing is all it is it's mild dissociation. It's chemical dissociation. It's not. There are certain mood disorders that we don't treat. We don't treat like schizophrenia, certain dissociative disorders like DID, or we don't, and certain personality disorders like borderline personality disorders. These people, they already have a fluctuating reality. And so in those cases, this is not a recommended treatment, at least not in the outpatient setting. But like with PTSD, I'm using PTSD because that seems to be, I feel like that applies more to our target audience here. And what we're seeing there is the dissociation. It's mild and it's short-lived. It means while you're getting it, so they come in, we do the consultation, then we schedule 6 appointments. We do 2 infusions a week for 3 weeks. Each infusion lasts about 40 minutes long. Each appointment's about an hour and a half. And during the infusion, the patient feels very low dose anesthetic effects. So they feel kind of floaty, but when that protein releases in the brain, that floaty feeling becomes almost very personal, and that's one of the things that people lean into. They lean into this from an experiential standpoint, but believe it or not, the experience is not what fixes you. It's that night when you're sleeping, we release the proteins with the ketamine, but that night when you're sleeping, those proteins become neuroregenerative, and that's when the good happens. And so it's not something you have to think about. It's not something that the patient can mess up, because they're not the ones actually doing it. There are many places that will sell this as a psychedelic experience, but I feel like that's a very lazy way of approaching it, because it's really just it's a way of saying, well, this is just magic, so trust the process. Education is very important. If the patient is well educated in the process to the peak of their ability, and that helps them set adequate expectations from treatment, then they do very well with treatment. And that's a big part of what we do, is we're very big on education.
What are some of the apprehensions that you see from from someone that's thinking about using this treatment?
People, I think you mentioned it before, like we were talking about, what are the long-term side effects? There's been a longitudinal study done with over a 10-year period. Patient did an initial stabilization of 6 infusions, and then they did an infusion every week after that for 10 years. Even after that much, there's no evidence of physiologic dependency because it's intravenous. And so it's not one of these things that stays in your body for a long time and the body gets used to. It gets in, it elicits its effect, and then it gets out. And so within 2 to 4 hours, all the medication that we gave is out of the patient's system. It actually decreases your chance of developing dementia and Alzheimer's as you age, because it is neuroregenerative. I had somebody ask me the other day, so basically everybody should do this. I was like, yeah, at a certain age, probably. At a certain,
I was going to ask, is it like a preventative thing as well?
If you have, they have a genetic testing they can do now for Alzheimer's, which is something that I've had a few patients that have had, because they know that it runs in their genetics. And if they have the markers for it, then we will begin a protocol in treating them as a preventative. Yes.
Wow.
Wow, man. So you said something earlier before we keep going, that you wanted to be something that was anti-recession.
Yeah. Yeah.
Well, I tell you what, you're actually on, because mental illness is so new. People are really starting to treat it recently.
Well, it's not new that the
It's-
acceptance and the talking about it is
Right.
Yeah. Yeah. Yeah.
The old way was deal with it and carry on, right?
right.
Yeah.
So,
Suck it up.
yeah,
You
you're
know?
cutting edge. You went to something not only anti-recession, but it's cutting edge. And that's awesome. And I just can see such a benefit from this, vice the narcotics or opioids or whatever antidepressant people are on these days. Because once you're not on this stuff the rest of your life, you have what, 6 sessions, I think you said, and then you're not saying you're over it. You're still going to have
No, it's you see, you still utilize the same things that we've always been doing. It's like counseling, because counseling works.
Yes.
The problem is that not everybody's in a place to make progress with counseling, especially these guys that are just struggling to make it through the moment.
Right.
Counseling has a limitation. What we do is once we get the brain functioning optimally from a wiring perspective, we're just getting communication enhanced to the point to where, the brain is running at its peak. And then when that's the case, the control that each of these young men and women have over their minds is so powerful. They can, the emotions are all still there, the feelings are there, the traumas are there, but they don't have control. And that's, it puts the logical mind back in the driver's seat. It's, and it's the reason it works is the reason we know it works is because it's mappable, it's measurable with a functional MRI. We're able to, I know Dr. Amin in Atlanta, he does neurotherapies like TMS therapy. And I know he's done some, looking into ketamine infusion therapy as well. They all do the same thing. They stimulate the brain's ability to self-optimize. It utilizes what's already built into us to heal us. It's just kind of intuitive. You think about it.
Yeah.
And your uncle has, how I met you, has told me some amazing stories about your results of people, no names, obviously, I don't hate to give any names, but some awesome things that happened to these people, how much better they've gotten. So what have you noticed the success rate of the ketamine infusion?
So after stabilization, which is the 6 infusions we discussed earlier, 85% of patients, between 85 and 90% at our clinic currently, that's our current ratio, report complete remission of these depressive symptoms.
My gosh.
Oh my God, that is better than any medication I've known people to be on.
Your antidepressant therapies, SSRIs, SNRIs, they typically at best can report about 35% of patients report satisfactory remission of symptoms. And that rarely lasts that rarely possesses the longevity over time. It's usually they work for a while, but by increasing neurotransmitters in the brain, it's hyper stimulating the neurons to communicate better. So that's what they're doing, is by increasing certain neurotransmitters, we increase the brain's ability to communicate. It's like running a motor at 7,000 RPMs all day long. You're going to end up burning it out.
Yeah.
Once you burn that pathway out, you either have to increase the dose to elicit the effect or change medications, which is what we see until eventually the vast majority of people become what we call treatment resistant.
Yeah. Or especially with the people with suicidal tendencies or whatever they call it, ideologies.
Yeah, the suicide ideology is one of the things that we do best at. It's
right. I saw that on the website. Definitely.
That's so amazing, because when you think about PTSD, when you think about suicidal ideologies, depression, and these mood disorders, you think that once diagnosed, you have to live with them forever.
Yeah.
And that you just get, deal with them and kind of like pain management. Well, you're going to be, have PTSD forever. So let's just give you this medicine for the rest of your life.
Yeah. Here's the thing is, you're right. We can't take back the trauma. They will there'll never be 100% again. Okay. But getting them back to, 90, 95% is not off the table anymore. And it's because these mood disorders, they're very physiologic, just like, say, a broken leg. I mean, it's I hate to boil it down to that, but it's if this was just a thinking problem, if this is something they could have worked their way through on their own, they would have by now.
Yeah.
And that's something that needs to be recognized and said out loud, that this is not something that they have the ability to just think better and do. It's
Right.
as much as we would like that to be the case. This is a neuronal injury. Just like I said, if you look at it under a functional MRI, it looks just like somebody hit you in the head with a hammer, or you had a stroke in that area and that brain tissue doesn't work anymore. The thing is, though, it's not dead tissue; it's dormant tissue, and so it can be reawakened easily.
So a stroke victim, whatever part that stroke got affected, the brain that stroke affected, can be healed.
With the stroke victim, it depends. So like there are some, like wherever the stroke occurred, there's tissue death. And when there's tissue death, this is a whole very different thing. We can't reawaken that tissue. And so the best we can hope for in those scenarios is rapidly rewiring, around this. And then the brain has the ability to correct to an extent. We've treated a fella who recently, he had a severe COVID infection in December. And he was also a vet. And he had a stroke, which is so common with severe COVID infections. And he had he's lost like 4 or 5 of his family members, over like a 2 or 3 month period with severe COVID infection. And but in his case in particular, his stroke, he got a left-sided paralysis. He got an aphasia, which is the difficulty to get he could think right, he could think the words, but he couldn't get his mouth to say them. He started seeing us about a month and a half ago, and he is communicating better. His balance is coming back. He's actually hoping by the end of the year to start driving again.
Oh my gosh.
Wow, that's phenomenal.
The brain is very mechanical. It functions on a very stable and set of rules, just like the rest of our bodies do. It's very subconscious, meaning that it's not something that you can always think your way through. Now, you do have psychological control, and you can build neuronal pathways through practices and coping mechanisms, but that, once again, it only gets you so far. The tissue has to be there and functioning to do so.
As we get ready to close out, Doc, there's one thing that you said earlier, or a couple of minutes ago, and I just really want you to kind of expand on it, because so many of us are hesitant to get treatment for mental health, especially with the stigma attached to it. And you said, if you could think better or do better or think your way out of it, you'd have already done that. And I think that that's one of the hangups that I see a lot with service members, is that we're like, well, I'll just battle it out. I'll just keep going, I'll keep thinking positive. I'll keep doing this. So if you could just expand a little bit more on that to close us out.
Absolutely. There's this famous old expression, pull yourself up by your bootstraps.
Yes.
People use that as this, it's like this self-made man, this idea that I can get myself out of it if I work hard enough. Well, if you look back at the origin of that statement, it's that phrase, it was meant to describe something that was futile. It's like trying to, pull yourself on a rope that you're holding above your own head. It's not possible. Pulling yourself up by your bootstraps was an impossible task. And that's what this is. And that's what I want to remind our servicemen and women, is that when you've been through this is not something that you did wrong. This is not something that you think wrong about. This is an injury that happened to you. It's just not a visible one. It's not, not always a missing limb or something that some people can directly connect with and say, oh, that's the problem. But what it is, it's a processing issue. We aren't designed to process some of the things that we go through. And when these things happen, it's an area of the brain shuts off. It's like trying to, I guess as far as a thinking problem goes, this is not, if it's like trying to will yourself to heal faster. It can't be done. It's like you can hope and wish and pray it will happen, and that's all well and good. And I think that's, positive outlook goes a long way. But at the end of the day, from a mental health perspective, your brain is tissue. It communicates through the movement of electrons and electrical communication through certain neurotransmitters that the brain is constantly releasing and picking up. And it's not something that you even think about or can control. Anyway, I want to make sure that they understand that this is a physiologic problem, just like an injury, and it's mappable, it's measurable, and we know this now. This isn't something that is theoretical. This is, with the functional MRI, being able to image living human brains for the first time ever, really, and see how they're working. It's before that, everything was just guesswork.
Yeah.
I love how you put it, because a lot of times we think like, I'm just stronger than that, because we put ourselves in so many mental, where we have to just mentally overcome. And so you think you're stronger than that. Well, if you break your arm, you can't go lift 100 pounds because you're just not stronger than the break.
Right. And that's exactly it. And the thing is too, and the reason I think all my vets do well, and because they do, my PTSD guys, my vets, my first responders, we do a lot with our local police officers. These guys do so well with treatment because this was never a thinking problem. This wasn't a neglecting of mental health that led to a worse scenario. This is something that happened to them. And so when they see, when we get the wiring communicating effectively and they see a way out, man, they run for it. Right. And they do the work to help recover. But it's a lot like I put it like a knee replacement. If you have a knee replacement, that's what the ketamine infusion is we get a brand new knee without any structural problems. But then you have to do the physical therapy to make sure you rebuild the muscles. You have to make sure that you're supporting it appropriately to make sure that when it heals the way it should, and you don't just create a whole nother problem. And so we're by no means a magical fix. But we are the best chance for these guys. And this should be available to everyone.
Yes.
Yeah, man, this was awesome. I learned so much from this episode.
Thank you so much for coming on.
Thanks you so much for having me. We work very hard to educate our first responders and veterans locally. And I think this next week I'm meeting with our local Veterans Administration leaders on trying to get something worked out to make this readily available and minimize the cost, if any cost at all, for our vets. This is because, like I said, they just do so good.
Is there anywhere where our listeners could get more information, a website, a social media page, or anything?
Absolutely. One of the best places to look, our website has a ton of information. It's www.scenic, like SCENIC, city, CITY, and then neurotherapy. And that's what we call our treatments. It's just like physical therapy or psychotherapy, it's neurotherapy. So sceniccity.neurotherapy.com.
Yeah, we'll definitely put that out on our Facebook page so that our listeners could go and click on the link there.
Right. And we're about to close out, but Charles, if you could hang out for a second, and I'd like to talk to you for a quick minute before we let you go.
Absolutely.
All right. With that, we'll wish you fair winds.
And following seas. Stop recording.
Okay, he's just gonna stop recording so that we can chit chat. That's such great insight that we didn't. Like I said, it's not something that we've heard of, and being two veterans who are dealing with mental health, it's like, why haven't you told us about this?